Tonight we have two amazing presenters from San Diego Start with us tonight, and I am going to let them take it away and present to us on a very valuable topic. This month is May is always Mental Health Awareness Month, and so this is a very appropriate topic for tonight. We want you guys to hear this great information. So welcome, thank you, and we'll let our presenters take it away. Thank you.
Hi, everyone. Thank you for being here tonight. My name is Juliana Hartzog. I am a licensed marriage and family therapist, and I am the program director for San Diego Start. And I will let Wajdi introduce himself.
Hello, everybody. My name is Wajdi Fakori. I'm the clinical director for San Diego Start. I'm also a licensed marriage and family therapist.
Starting out a bit about START and who we are. So START is a crisis prevention and intervention program. We are vendor through the San Diego Regional Center, and we support individuals and their families who are navigating mental health and behavioral health crises. So this evening, we're here to talk about co-occurring mental health disorders in autism and in intellectual and developmental disabilities, often referred to as IDD. So this short training, the goal is not to turn anyone into a clinician or diagnostician. The goal is to help parents recognize when something may be more than just a behavior, understand why mental health symptoms are sometimes missed, and know what kinds of questions to ask when seeking support. Research shows that approximately 70% of individuals with IDD have at least one co-occurring mental health condition, and up to 40% may have two or more. And it can often be missed because they simply look different. So here is our roadmap for tonight. We will start by connecting this topic to Mental Health Awareness Month and the larger shift in how we understand autism, IDD, and mental health. Then we will review why symptoms are often missed. One of the most important ideas in today's training is diagnostic overshadowing. This means real mental health, medical, or trauma-related symptoms may be overlooked because they're attributed to autism, IDD, or quote-unquote just a behavior. We will then briefly review common mental health concerns, but in a parent practical way. We will not spend most of the time on diagnostic criteria. Instead, we will focus on what parents may notice at home, at school, really in your day-to-day life. We will then end with what you can track, what you can ask providers, when to escalate, and what resources may be available locally. We'll also have 20 minutes reserved at the end for Q&A. We are intentionally keeping the teaching portion focused. The deeper diagnosis by diagnosis details will be in the take-home tool. All right. So May is Mental Health Awareness Month, and this is important. This is an important opportunity to make sure people with autism and IDD are included in conversations about mental health. For a very long time, systems did not do this well. People with developmental disabilities were often viewed only through the lens of their disability. If someone was crying, aggressive, withdrawn, not sleeping, refusing day-to-day activities, those changes were often explained as just autism, just disability, just a behavior. We now know that is not enough. Autism and IDD are neurodevelopmental conditions. They are not mental illnesses. There is a diagnostic manual that is used by clinicians known as the DSM-5. And the DSM-5 classifies autism and intellectual disability as neurodevelopmental disorders, which are distinct from mood disorders, anxiety disorders, psychotic disorders. But it explicitly recognizes that these conditions frequently co-occur. The important clinical point is that symptoms may look different. A person may not say or be capable of saying, "I feel depressed." They may stop participating. They may lose interest in favorite activities. They may sleep more, become more irritable. They may not even be able to say, "I am anxious." They may avoid, freeze, ask repeated questions, become rigid. So today is about replacing blame with curiosity.
Righty. Before we talk about specific mental health diagnoses, we need to ground ourselves a bit more in IDD. So IDD is an umbrella term, and it does include intellectual disability and other developmental disabilities, including autism. Autism can occur with or without intellectual disability, so we do not want to assume that those terms mean the same thing. Excuse me. IDD may influence how a person communicates distress, process information, experiences, sensory input, may affect how one navigates relationships and even build daily living skills. This matters because we do not want to pathologize someone's baseline disability-related needs. A need for routine is not automatically OCD. Sensory sensitivities does not automatically mean anxiety. A focused interest is not automatically a symptom. So, at the same time, understanding IDD does not mean ignoring suffering. So, if someone is distressed, losing skills, withdrawing, not sleeping, hurting themselves or other people, um, or even no longer functioning the same way that they used to, we should take that seriously. Um, So the balanced message is this: understand the disability and assess the distress. We do not want to over-pathologize IDD or autism, but we also do not want to miss treatable mental health needs. So there are many reasons mental health symptoms are often missed for people who are navigating intellectual and developmental disabilities, including autism. So first, communication differences matter. Some people cannot easily describe worry or sadness or fear or intrusive thoughts, hallucinations, trauma memories, or hopelessness. Second, some people have difficulty identifying internal states. Um, you know, they may have difficulty recognizing and naming emotions. It is estimated that about half of individuals who navigate autism have vulnerabilities in this area. They may feel something in their body, but do not have the words to say, I am anxious, or I am overwhelmed, or I feel unsafe. Third is sensory processing differences, and they can certainly intensify distress. Noise, lights, crowds, transitions, unexpected changes, um, medication side effects, these can all affect mood and behavior. Fifth, many people with IDD have experienced trauma, bullying, exclusion, restraints, hospitalizations, loss of control. Um, so when we see behavior, we should treat it as information. It may be the visible signal of something deeper. So diagnostic overshadowing is one of the most important concepts, in my opinion, for families to understand. It happens when real symptoms are overshadowed by a person's existing diagnoses. So, for example, if someone becomes aggressive, people may say that is because he has autism. Maybe autism-related sensory overload or some communication frustration is a part of the picture. Yeah, maybe that's true. But maybe, this individual has anxiety. Maybe he's in pain. Maybe he is traumatized. Maybe he is depressed. Maybe demands are exceeding his capacity. If someone refuses school or day program, for example, one might say, she's being non-compliant. But maybe she's being bullied. Maybe she's having trauma symptoms. Maybe she's exhausted. Maybe she cannot tolerate the environment. Maybe she does not have the communication tools to explain what is wrong. Diagnostic overshadowing can happen in the opposite direction too. So if someone talks to themselves, people may assume psychosis, but it may be self-talk, scripting, fantasy, memory, or a way to organize thoughts. The point is not to jump to any one explanation right away. The point is to stay curious. There's a lot of evidence in the literature that suggests that diagnostic overshadowing is a very real phenomenon. Clinicians who are shown identical symptom profiles are less likely to identify a mental health condition when the patient also has a co-occurring intellectual or developmental disability. So diagnostic overshadowing can really delay medical diagnoses. We think of, pain, GI conditions, seizures. These are all much more common in this population and can present as behavioral change. So the better question to ask is, what changed and what might be underneath the change?
All right. So this slide highlights our first tool for today. And this may be the most practical tool, change from baseline. So as parents, you are the experts. You often know baseline better than anyone else. You know what is typical for your child or your adult family member when they are doing relatively well. So when something changes, that change matters. For instance, sleep is one of the biggest areas to track. Is the person sleeping less? Are they sleeping more? Waking throughout the night or waking up very early? We can then look at appetite. Are they eating more? Are they eating less? Are they avoiding foods they usually tolerate or even foods that they like? Are they losing or gaining weight without an explanation? We can then take a look at energy. Are they slowed down, restless, agitated, or unusually energized? We can then look at participation. Are they refusing school, work, day program, hygiene tasks that they typically do pretty independently? Are they are they refusing to engage in their favorite interests and favorite activities? And then this brings us to safety. Is there more aggression? Is there self-injury, elopement, suicidal talk, or in general, is there risky behavior that's an imminent safety concern? Then we look at the context. Did something happen before the change? Was there a move, a change in schedule and routine? Was there a loss of a family member or a loss of preferred staff? Is there family stress? Even puberty can be an onset. So when you go to a provider, if you say, this is a change from baseline, they will take notice. It is one of the most important things you can say. So on this slide, we're provided a checklist. When something concerning happens, it is understandable that people focus on the behavior itself. But behavior is a visible signal. It is not always the root problem. If someone is hitting, refusing, crying, yelling, shutting down, or running away, we need to ask what is underneath. Could there be pain? Is there a medical issue going on? Are they constipated? Are they having acid reflux, dealing with headaches, experiencing seizures? Or are they sleeping or not? Sleep is especially important. Research shows us that sleep problems affect 50 to 80% of people with autism and IDD, and poor sleep alone can worsen mental health symptoms. So always ask about sleep before assuming a behavioral explanation. We can also ask, is this anxiety or depression? Could this be a trauma response? Could the person be stuck in a fear response? We can also look at, is this a sensory overload? Is the environment too bright, too loud, too noisy? We can also look at communication frustration. Is the person being asked to explain something that they might not have the words for? The goal is not to excuse unsafe behavior. The goal is to identify what support is actually needed.
So anxiety is one of the most common co-occurring mental health concerns in IDD, including with folks navigating autism. But it may not look like the textbook version of anxiety. Many families might be waiting to hear something like, I'm worried. But some individuals may not have the language or the insight, the body awareness to say that directly. So instead, anxiety may show up as refusal, avoidance, repeated questions, crying, irritability, aggression, shutdown, or suddenly needing more help with daily tasks. We also should consider overlap because anxiety can look similar to trauma, depression, pain, or even biomedical concerns, including medication side effects. So when anxiety is suspected, you know, these should also be considered as well. When we say adapted psychotherapy, there are actually specific programs with research behind them in the context of IDD and anxiety. So evidence-based anxiety treatment often draws from CBT or cognitive behavioral therapy, but it has to be adapted, using visual supports, concrete language, shorter and slower teaching, role play, caregiver involvement. And for anxiety in younger folks with autism, programs like behavioral interventions for anxiety in children with autism protocol have been tested in clinical trials. For adults, mindfulness-based programs, as well as acceptance and commitment therapy, sometimes you hear it ACT. These have shown a lot of promise. So parents, can really uh, do a service to themselves and their family if they ask providers, are you using an adapted protocol? Which one? That is a fair and an important question to ask. How are you adapting therapy? Medication can also help when clinically indicated, but it's important to know that, especially for anxiety, if medication is, involved, psychotropic meds, um, it's best practice to do it alongside other interventions, including psychotherapy. The takeaway is anxiety may make ordinary demands feel very unmanageable. And one of the goals is not to force compliance, but rather to really understand the anxiety, understand the fear, reduce overload, teach coping skills, and build tolerance step by step. Depression can also be missed because it may not show up in obvious ways. So for people navigating IDD, including autism, depressed mood may present as irritability, aggression, crying, withdrawal, or a major drop in participation. Some of the core symptoms include, depressed mood, but also reduced interest in activities, weight or appetite changes, sleep changes, changes in energy levels. Difficulty concentrating is a big one. Feelings of worthlessness or guilt, and thoughts of death or suicide. So for parents, one of the most important warning signs is loss of interest. If, your son, your daughter, your loved one no longer wants to engage in favorite activities, they no longer participate in family routines or even familiar routines, or if they seem really disconnected from things that they usually enjoy, that should really be taken seriously. Studies have found that, autistic adults have significantly elevated rates of suicide attempts compared to the general population. Depression in this population should always include a safety assessment, even when the person has limited verbal communication. Because, behavioral indicators of, let's say, hopelessness and withdrawal should be taken very seriously. So treatment should always begin with a biopsychosocial assessment. That means we look at, biological factors like sleep, pain, appetite, medications, medical issues, perhaps, thyroid condition. We also look at psychological factors and social factors like isolation, bullying, family stress. Therapy can help, absolutely. Psychotherapy can help, and there are specific approaches. So adapted CBT has the strongest evidence for depression in autism. For adults with ID or intellectual disability, behavioral activation programs, specifically, Beat It and Step Up, are the best studied. DBT can certainly help when depression really co-occurs with emotion dysregulation or self-harm. Mindfulness-based therapy and ACT are alternatives, especially for people who struggle with the cognitive demands of traditional CBT. Studies found that incorporating the PERMA model, which is Martin Seligman's PERMA model for well-being, that the studies suggest that that incorporation reduces depression. And what's really nice about that is the PERMA profiler has been validated in this population. So it gives us a strength-based framework instead of only asking what is wrong, we also can ask what helps this person thrive. Medications such as SSRIs are also commonly used in consultation with a prescriber, of course.
Okay, so this leads us to trauma and PTSD. Trauma and PTSD are especially important in autism and IDD because trauma is often missed when extreme stress reactions are interpreted only as behavior. The core PTSD domains are exposure to actual or threatened harm, intrusive symptoms, avoidance, changes in mood or thinking, and arousal or reactivity symptoms. In IDD, the traumatic event may be something adults underestimate. This can look like a serious illness, bullying, sudden placement changes, restraint, seclusion, loss of a caregiver or loss of preferred staff, or repeated experiences of fear or loss of control. I do want to highlight restraint and seclusion, which some individuals experience in school settings or residential settings, and can in themselves be traumatic, even when they are used with good intentions. Not every person who experiences trauma develops PTSD, but many experience lasting impacts. Research estimates that up to 90% of people with IDD have experienced trauma or adverse life events. A key clinical point is that PTSD may be significantly underdiagnosed in this population. One clinical study found that only about 3% of individuals with IDD and known trauma exposure had a formal PTSD diagnosis. And this suggests to us that trauma responses are being attributed to other causes. So in the home, in day-to-day, parents may see symptom or behavioral presentations like avoidance, fearfulness, sleep disruptions. You may see regression in previously mastered skills, hypervigilance, aggression, self-injury, shutdown. There may even be instances of reenacting the trauma events. The person may not be able to explain the memory verbally, so the reaction may look like concrete and behavioral presentations. So treatment should begin with a trauma-informed approach. So first, of course, looking at safety, including predictability, promoting choice, sensory regulation, grounding, and de-escalation. And there are evidence-based therapies as well, like trauma-focused CBT, EMDR, or DBT. These approaches may be helpful when they are adapted to the person's developmental and communication needs. This leads us to bipolar disorder. So bipolar disorder requires careful assessment because it can be easily confused with emotional dysregulation. The key clinical issue is whether there is a sustained mood episode that represents as a noticeable change from the person's usual behavior or their baseline. So this tool lists a prevalence at 2.3% in IDE and 2.8% in the general population, which may suggest similar rates. However, some population studies suggest that when bipolar disorder is carefully assessed, people with IDD may actually be at an elevated risk. But it can be that the diagnosis is often missed or again attributed to emotional dysregulation. The important point for parents is that these numbers may undercount the true rate in the IDD population. Now, breaking down the two types of bipolar disorder. Bipolar 1 involves a manic episode with elevated, expansive, or irritable mood, plus increased activity or energy for at least 1 week. Bipolar 2 involves hypomania, which is really a milder form of mania that lasts at least 4 days, plus a major depressive episode. In IDD, these symptoms may look behavioral. So they might present like aggression, increased irritability, physical outbursts, impulsivity, again, sleep disruptions, even appetite changes or difficulty expressing emotional experience. But there is a caution for parents. And that caution is mania is sustained over time. Dysregulation will come and go. And emotional dysregulation is often in response to something else. And that something else can look like demands, sensory overload, frustration, anxiety, trauma reminders, or communication breakdown. However, for bipolar disorder, support usually involves a combination of psychiatric care, medication when it's indicated, therapy, family education, sleep stabilization, and wellness routines like what she had mentioned earlier with PERMA.
So obsessive compulsive disorder, OCD, it can be tricky to identify in people who are navigating IDD because repetitive behaviors are common in both. The key difference is what drives that behavior. In autism, routines and repetitive behaviors are often soothing, uh, organizing, or comforting. But in OCD, the repetitive behavior is really driven by distress. The person feels they have to do it to reduce anxiety, and they often wish they could stop. So the question for parents is not, is this repetitive? The question is this comforting or is this distressing? Watch for cleaning, checking, counting, repeating, um, or doing things over and over until, they feel right. If the behavior seems to cause anxiety rather than relieve it, or if it's getting worse, if it's taking more time, or if it's interfering more and more with daily life, then that's something that you should absolutely bring to your provider. OCD symptoms are estimated in 20 to 37% of people navigating autism, and 1 to 2% of people with other intellectual and developmental disabilities. But not every ritual is OCD. And, careful assessment matters to avoid mislabeling in either direction. So assessments should consider things like, developmental level, magical thinking, and the person's ability to describe their internal distress. Adaptive therapy, including CBT, can be really helpful. Key adaptations include, focusing more on the behavioral component and the cognitive elements, using visual supports, concrete language, special interests to promote engagement, and also, when appropriate, high caregiver involvement. So there are a couple of interesting ones I wanted to highlight. So function-based CBT combines CBT principles with applied behavioral analysis. In a study including children with autism showed quite large effect sizes for reducing OCD or obsessive compulsive behaviors. There's also an autism adapted CBT manual for adolescents in OCD. I believe it's on, yeah, by Jossie. And interestingly, um, it showed over 50% response rates and continued improvements at 3-month follow-ups. Medication options may include things like SSRIs, SNRIs, of course, under prescriber guidance. Psychosis can occur in people navigating IDD, including folks who navigate autism. But this is an area where careful assessment is really essential because some things that look like psychosis are not. Core symptoms of psychosis can include things like delusions, hallucinations, disorganized speech, disorganized or unusual behavior, diminished emotional expression. In someone with IDD, these can be really hard to identify, especially when communication is limited or when baseline functioning already includes differences in thinking, in speech, or emotional expression. But at the same time, people with IDD may do things that look like psychosis, but likely are not. They may talk to themselves to organize their thoughts. They may script from movies or shows. They may have imaginary friends, engage in fantasy. Um, um, they may be filling in memory gaps with stories that feel real to them, but did not really actually happen. Sensory sensitivities and unusual thinking patterns in autism can also be mistaken for hallucinations or delusions. Psychosis does occur at higher rates in IDD. So approximately a 3% compared to maybe about 1% in the general population. So the goal here is not to dismiss concerns, um, uh, but it's really to describe exactly what is being seen and heard, so that you can relay that information appropriately to your provider. So there are some helpful questions that you might want to ask, or to ask, is this new? Is a person frightened? Is there a decline in how they are functioning? Could this be related to sleep, medications, seizures, or a medical issue, including medication side effects? Um, Several, medication side effects from, anticholinergics, steroids, stimulants, for example, can all produce psychosis-like symptoms. So if psychosis is confirmed, supports may include psychiatric assessment, antipsychotic medications when clinically indicated, routine and predictability, um, psychoeducation, including psychoeducation to families or caregivers, safety planning for crisis episodes, and there are CBT protocols like CBT for psychosis, but the evidence is definitely there that it works. But the evidence really is only looking at the general population. There haven't been as many studies specifically to the IDD population.
Okay, so after today's presentation, we will be sharing a tool on co-occurring mental health vulnerabilities in context with IDD. The purpose of this tool is not to diagnose by any means, but it is intended to help you organize all. So the first thing to look for is change from baseline. So what is new? What is worse? What is happening more often or less frequently? And what has a person stopped doing that they used to enjoy or tolerate? The second step is to look at how symptoms may present differently in someone with autism and IDD. For example, anxiety may look like refusal, depression may look like irritability, trauma may look like aggression or shutdown. OCD could be confused with routines, and psychosis may be confused with self-talk, scripting, sensory experiences, or confabulation, which is essentially a fancy word for false memories, or it's also known as honest lying. The third step is to remember that the same behavior can have many causes. So before assuming a diagnosis, we want to rule out any medical issues, um, any medication effects, trauma, sensory overload, breakdowns in communication, and environmental stressors. So again, the parent takeaway is to say, this is a change from baseline. Then ask, what should we rule out? And what supports can we begin now? Now on this slide, this is where we bring everything to action. So no matter which diagnosis we are talking about, several supports matter across all of them. So we always start with medical rule out. Really, this isn't an option. Pain, constipation, reflux, seizures, even UTIs or dental problems, they can all drive major mood and behavioral challenges. If a medical issue is missed, no amount of therapy or medication will fix it. Next, we assess sleep. Again, sleep problems affect 50 to 80% of people with autism and IDD. Poor sleep alone can worsen a number of mental health symptoms like anxiety, depression, aggression, irritability. It can even cause psychosis-like symptoms. So if sleep is disrupted, address it before assuming the problem is purely psychiatric. Then we review medications. So medication changes, missed doses, side effects, and drug interactions can all change and impact behavior and mood. It can be extremely beneficial for parents to keep track of current medications, like keep a current medication list and bring it to every appointment with every provider. So once medical, sleep, and medication factors have been addressed, we focus on daily supports. So we incorporate predictable routines, visual schedules, and sensory regulation strategies to help stabilize the nervous system. And finally, coordination matters. So parents, schools, regional centers, really everyone in the system, in the atmosphere, need to have a shared understanding of the plan, especially when safety is a concern. So when teams are not communicating, individuals and families can fall through the cracks.
All right. Sometimes families know something is wrong, but are not sure how to say it in a way that their provider will actually hear. The most important phrase is, "This is a change from baseline." That tells the provider that this is not just a behavior in isolation. Something has shifted from the baseline. We want to then ask three questions. What should we rule out? This opens the door to medical, psychiatric, and environmental causes. The next question is, what should we track? This helps a provider tell you what data would be most useful. Sleep logs, mood patterns, behavior frequency, even bowel tracking. Uh, the next question would be, what supports can start now? This really helps prevent waiting months for a full evaluation, while the person continues to struggle. We want to bring concrete information, examples with dates and times, a sleep log, a current medication list with recent changes, and any recent stressors, losses, or safety concerns. The more specific the information, the faster the team can move to a clearer path. Some situations cannot wait. If there is suicidal, talk or gestures, self-harm, new or severe aggression, unsafe elopement, refusal to eat or drink, severe sleep loss, new psychotic symptoms, major aggressions, we can, of course, schedule appointments, but there's always, the option of calling 911 for any immediate danger. Of course, there's always, an option of calling or texting 988 for mental health crisis support. And I always would recommend that if you do call 911 regarding a loved one with IDD, to let them know that, Wajdi has autism and is experiencing a mental health crisis. Um, we will be sharing a few more resources on the next page.
Alrighty, so on this slide, we do have the resources that Wojdi had mentioned. I do want to be mindful of our time, so we'll go through them rather briefly. And of course, we encourage everyone to look them up and research on your own as well. So 98 is a mental health crisis line available for community use. Similarly, so is the San Diego Access and Crisis Line. However, the Access and Crisis Line can dispatch MCRT, or also known as the Mobile Crisis Response Team, if in-person support and assessment is needed. And of course, if safety is an immediate concern, always contact 911. 211 San Diego connects community members with community resources and support services. We also have NAMI San Diego, which provides therapeutic and education programs for individuals experiencing behavioral health challenges. We also have the Autism Society San Diego Ask Line. So this is a peer-to-peer line that can provide resource information on really a wide range of topics. So anything from IEPs to mental health services to regional center programs. We then have us listed as well. Again, we are San Diego START. We are a crisis prevention and intervention program that is vendored through the San Diego Regional Center. We also have Exodus Recovery, Inc., which has a number of programs under it, like the Crisis Stabilization Unit, Project Connect, which is also on here, is under Exodus Recovery, and they deliver individual and group therapy services to individuals with IDD. On this slide, we also have our take-home tool. So as a reminder, the intention of this tool is not to diagnose. It is a way to organize observations and prepare more specific conversations with providers. So again, when using this tool, we start with the symptoms. What are the changes from baseline? Then we ask how these symptoms may look differently in autism or IDD. Then we begin to rule things out. So when we rule out what it's not, we can then narrow down what it is and provide appropriate support.
So we will be sharing on these slides, but thank you all for being here tonight. We will pause here and move into our Q&A. But before we start our Q&A, I just wanted to let you all know that we facilitate these trainings very often, multiple times a week even. So any input, feedback that you might have would be much appreciated as we continue our efforts in improving these community trainings and opportunities. Feel free to scan the QR code when you guys are ready, and you can complete the short survey through that link or the QR code. And with that being said, we can move to our Q&A portion.
Thank you guys. Really, really appreciate it. There was so much incredible information here to be shared. And I mean, it's almost overwhelming. I'm so glad we're recording this because there's so much to take and want to go back and refer back to. I mean, the wealth of valuable information and just observing every single possible avenue when your child doesn't, something seems to be off, all the different avenues that you can check, and also, triaging which ones are the things that you should check first and the priority is fantastic.
Yeah, absolutely. If you could repeat sort of that bullet point list that you had when you're really looking at, again, the number one question is what changed from baseline? We definitely heard that over and over. So there's sort of almost like a 5-step checklist. Do you guys want to go over that again? We would love to hear it.
Yeah, absolutely. So when we're referencing this tool, we start out with what are the changes in baseline. We want to take a look at how these symptoms might present differently in individuals with IDD and autism. I just want to make sure I'm referencing the same thing. Are we referencing the
Yes,
tool?
that's it.
Okay, fantastic.
Yeah, I think that was so helpful.
And then we want to rule things out, really. We want to rule out any medical conditions, again, changes in sleep, which is highly prevalent in individuals with IDD and autism. Really, the overall goal is ruling out anything that can be biomedical in nature. Because again, if it's biomedical in nature, no amount of therapy services are going to address the underlying problem. And then the next thing is bringing it to a provider and then stating with the provider, this is the change from baseline that we're seeing.
Yeah. So good, Juliana. Thank you so very much. This again is just such a valuable topic for our families because families, as you're listening to this, it can be overwhelming when you have that gut instinct that something more is going on. And I think it just validates that. I know years ago, we were told in particular, and I think the environment just was such that, the professionals would often say, autism and anxiety don't really go hand in hand. And it was fabulous to see that you guys are on that. And it does go hand in hand. And the studies are showing it absolutely goes hand in hand. And so, and I'm curious, again, this topic is so important because there's a gap of psychiatric professional resources seeing the need or understanding the population that is on the spectrum and being able to bring those two worlds together for the better of the individuals. And so we just can't say enough about how this is such a good topic. It's such an important topic. And I'm curious to know, does an agency like PERT know the resources that you just listed at the end? Because I think those are so valuable.
Short answer, yes, but I think
Uh-huh.
it does boil down to the PERT clinician individually. Um, a part of the San Diego Starts model is building community linkages. And
Mhm.
so we do currently have a linkage with PERT as well, where we've shared some resources. They've attended some trainings. But that is definitely something that's worth promoting and continuing.
Absolutely.
Mhm.
Because I think if and can you explain what PERT is to our families or just what it
Absolutely.
stands for? Uh-huh.
Yeah. So PERT is the Psychiatric Emergency Response Team, and they are contracted with sheriff's departments throughout San Diego. Um, they are not 24/7. I will say their hours really vary
Mm,
by which zone that they're in. But if you are experiencing a mental health or behavioral health crisis with your loved one and safety is an imminent concern, you could contact 911 and request PERT, where they would send out licensed clinicians to come and assess your loved one. And they either deem that and stabilize the current crisis, or if necessary, they can escalate into higher level care, which would typically look like hospitalization if that is deemed necessary.
yeah. So thank you for explaining that. And my curiosity comes from the fact that there's a higher percentage that occurs in our families with emergencies such as that. And so just the valuable resources that you shared, I think it'd be, yeah, keep going with that. We just want to encourage you to keep educating
Mhm.
the resources, the teams on the resources that you just listed, because again, when they come to a home and they're trying to help, uh, it'd be such a valuable um, addition to know if a family says, well, our child or our young adult has a diagnosis of autism or is on the spectrum, then they could go straight to those resources. I think that'd be great. But again, we get it. It's there's a lot to do there. So